emphasizing why it is so necessary and important to spare dose in the healthy tissue. And it is my pleasure to introduce Barbara Rombi, whom you all know very well, from Trento, and she will talk about the spectrum of pediatric patients referred to proton beam therapy.
Hello, hi everybody. Can you hear me? Yes. Okay. Okay, I will check. Thank you. Hi, thank you so much to give me the chance to present our population. We treated in our Proton Center in Trento pediatric patient, as you see. And then I would like to do very fast because I know that probably you are very tired, as I am. And then, first of all, since 1946 already, Robert Wilson realized that the proton treatment, a particle, can be used for a clinical issue based on the physical advantage of a proton comparing different type of radiation. And this is just a very brief schema about what we have in our Proton Center in Trento. As you see, we have a cyclotron here. And I'm sorry. Here we are. We have a cyclotron here, and then we have two beam line, and then we have a fixed line, and then we use the pencil beam scanning technique, which actually is an active technique. Basically, what we are going to do is just divide the tumor volume in layer, isoenergetic layer, and changing playing with the highest energy, we are able to cover the deepest energy layer, and then changing with the energy we cover the previous layer and so on in order to cover the full volume of the target. And then this is just our basis. So since 2015 up to September 2024, we have treated 581 pediatric patients. Let's say 1/3 are under daily sedation, and now we are able to treat 6 pediatric patients per year. 20% still are under sedation, so they are pretty small, below 6-year-old. And then, as you can see, the site of the treatment, 60% are CNS tumor, followed by 29% of sarcoma, and then we have the craniopharyngioma, 7%, 3% of skull-based tumor, and other type of the tumor. So from the local committee, they asked me to jump up and then to describe mostly the unique pediatric patient that we treated in our Proton Center so far. So we started the collaboration with the first patient in 2018, and then the last patient just went back at home a couple of months ago. So we treated 25 pediatric clinic patients. The median age is 10 years old, between 18 months and up to 20 years. 25% are CNS tumor, 75% are extra CNS. And then if you see the histology, most of the patients have rhabdomyosarcoma, different disease, different subgroup histology, and then size. They mostly are orbital parameningeal rhabdomyosarcoma, 5 other type of sarcoma, ependymoma in 2 patients, 1 craniopharyngioma, 1 adenocystic carcinoma, 1 medulla, 1 TRT, and 1 low-grade glioma. And then I try to focus where the patients are coming from Greek. So you can see mostly the most important are from Thessaloniki, and then the other one are from a pediatric hospital in Athens. As you know, in Athens there are 2 children's hospitals, and then I said Thessaloniki, and then from Heraklion, actually, the Crete University. So what we are going to do when we receive, let's say, an online call from our pediatric oncologist or radiation oncologist, which I would like to refer the patient to us. So usually we perform a weekly multidisciplinary team where we discuss the proper indication for proton irradiation. And when we accept the patient as soon as possible, let's say just one day after, we are able to prepare, to organize a proper formal letter in order to describe that we accept the patient. Why this is the reason is because sometimes those two forms take some time. So this is very important to keep in mind. It takes sometimes in order to get to be ready. And then because, as you know, we are working most of the time with a protocol and the patient are following a very strict international pediatric oncology protocol. It's very important to find the right time for and the right approval for this to form, as probably you know very well. So basically, we the same acceptance letter. We give also a formal plan with a formal date for planning and then the formal initial date. So the patient and the family can organize, of course, and then they'll stay at home. I mean, in our city. And of course, during the multidisciplinary team, what we are going to do, not only the oncological part for the proper staging of the disease, but most of the time we are focusing, try to check if there is a new assessment that has to be considered, let's say, needed to a neuropsychological support or physiokinesis therapy or other type of psychological support or ophthalmology evaluation. And then I forgot to say that in our Proton, in our institute, in the first floor, there is a pediatric oncology, the hospital service, which is actually is a great, they are doing a great job of supporting our Proton patient. And we are really working closer to each other in order to cover every need for our patient. And then again, for local committee asked me to present some few cases from the Hellenic state, and then I decided I choose a very 5 tricky cases. So this is the first one. Is a 7 years old. They're suffering from a multifocal rhabdomyosarcoma. I thought the type was an embryonal type. She had a tumor a tumor in the orbital region, and then the mass was pushing laterally in the optic nerve, and also there was a positive, the PET of the GPET was a positive for hypermetabolic lesion, which was involving, it was very well defined the CT as well as on the CT PET, the wing of the sphenoid. Also, it was like there was like a principal tumor followed by a two satellite, a small tumor, which was localized one in the top part of the orbit and the other in the middle part of the orbit. According to the FAR protocol, which was treated for chemotherapy, we didn't consider the nodules as a metastasis by definition of the protocol. And then, of course, with the pediatric radiation oncologist from Greek, we wanted to define the dose prescription as well as define the volume. So we treat her with two different volumes, the bigger one up to 41.4, plus a boost where the residual tumor was after induction of chemotherapy. And as you can see in the table here, we were able, not of course, even we will proton spare the lenses, the right lenses, but, and also the pituitary gland. We just went out of the limits, constraints limit up around 47, and then the average is between 18 and 40, I have to say. But we were able to spare the hypothalamus course, and then a part of the optic chiasm until day 52. And also we found a paper, this is a new paper which was published that comparing, put together the 395 children who are treated for meningeal rhabdomyosarcoma. They are part of the CDS protocol, but plus another trials. And then what they found actually that 90% of the patient got as a local treatment, radiation treatment, but in a different fractionation and also different technique. What they found that using a proton, there is of course, they developed a long-term sequelae, in particular in the endocrinological visual deficiency, but less than the other technique or hypofractionated technique. 5 minutes. Oh, what's happened to me? Really? So, and then this was another cases based on 12 years old affected by rhabdomyosarcoma. She had actually one single metastasis in the back half of the rib, but we decided to treat her just because, as you can see, the vision was right in the left paraspinal paraphrenic mass and the paraspinal space. She got a partial resection, and I know the quality is not so good, but there was a remaining part of the tumor. And then the problem was because under the first the surgery, they perform left nephrectomy. So they decided to send the patient to us because we were really able to spare those to the right kidney. As you can see in the table here, so the kidney just got 1.8 for the average dose, which was very high, 59.4 in 33 fractionation. And then this was another case, was a very, very pretty case, 15-year-old, affected by optic nerve, left optic nerve pilocytic astrocytoma. She was really resistant to vincristine, VCR carboplatin based on low-grade protocol. Was very resistant to even a BRAF inhibitor and MEK inhibitor treatment. So after surgery, which was partially resected, she went to our Proton Center, and then we were able to perform, let's say, hopefully definitive proton irradiation. This is was another case that we treated. It was this case required international discussion. The reason was because at the beginning it was like a localized G3 adenoma in the spine between L1 and L2. Fully resected. But when we saw the MRI at the beginning, as you can see here, and then postoperative MRI, there was like a pathological thickness. We went back to the Greek radiation radiologist, and then they confirmed that even though the liquor was negative, it was like a real evidence of a pathological disease. So for that reason, we open an international discussion saying what we are going to do in this case. Should we do just a local region between a D11, B12 up to S2? Should we propose craniospinal radiation, or should we do craniospinal radiation because of grading, high grade of disease? And then the answer from a pediatric radiation oncologist from the north part of Europe to come up with an agreement that probably she has to be treated with craniospinal radiation. We did it, and this is the technique that we performed to her, plus a booster here in the, of course, the primary region. as well as in the sacral part. This was from Capicello. Thank you so much. Just to show the difference, how dose distribution with, the technique, 3D conformal technique versus our technique. So what happened to her? The quality of life after the hand of the treatment was very good until she had a recurrence, a disseminated recurrence intracranially. Oh, if you want to know something about our technique, will be published in 2000, was published in 2015 by Paolo Faracek, a physics colleague. And then, of course, the advantage of proton radiation comparing photon radiation for pediatric brain tumor. So basically, what you have to keep in mind that with proton radiation, we are able really to prevent any damage in terms of processing speed and verbal memory. But using craniospinal radiation, even in the proton cohort, there is still improvement in the processing speed. So it's not, the solution. We also published our, preliminary results regarding the medulloblastoma patient, but because I have 1 minute, I will go so fast. So basically, we have 0 minutes, zero, zero, zero. Oh my God, 0 minutes. Okay. Let's keep in mind that we published and our results were very similar to the biggest results from the other bigger institution that treated medulloblastoma with proton irradiation. Last case was an ependymoma, was an aplastic one, group A, glostopper resection, ham0, and then we performed 59.4 gray in 33 fractionation. He was, a young boy, 2 years old, so we treated with adult sedation. And then we follow also the indication for the institutional paper that was published by Delin Delicato and Toro Yocco. They evaluated the toxicity with the proton irradiation in terms of brainstem injury, secondary malignancy, neuroendocrine effect, autotoxicity. I don't want to go through reading all the percentage, but we know that with proton radiation we really are doing better in terms of even reducing the brainstem toxicity. And also sorry, the secondary cancer incidence. So take home message. Proton radiation. So we consider proton radiation for curative pediatric patient. In fact, the longer the survivorship, the better is the therapeutic ratio for proton radiation. In case of dose escalation, for reducing the radiation-induced toxicity, and it's very important to open the discussion in a specific case like a retreatment and moving target cases. And just one suggestion, it's very important to maintain a keep open and multidisciplinary collaboration with international colleagues because it's very important to maintain the right time and to start proton radiation. And because we have a gap from the administrative part for to have S2 approval, so it's very important just to let us know as soon as possible that you have a patient that needs proton radiation. So we can be in time. And also it's very important to maintain a collaboration just for, not only for tumor control, but for evaluating the related toxicity. Last but not least, so we had in April 2024, the ambassador of Greek Eleni Sourani wanted to express the gratitude because we try to treat it as our best, the pediatric patient. Thank you so much. Thank you.
Thank you so much for sharing the experience here with the Greek patients. Really impressive numbers, and it shows that you have a very, very good collaboration. Because one concern raised before in one of the sessions was the time. And actually, when I get some inquiries, I also emphasize sometimes the timely initiation of the treatment is the most important, but the timeline you showed here is really impressive, and this seems to be an excellent collaboration.
Thank you so much. Thank you.
Any comments or questions?
Just 1 more minute, please.
Yeah, here closes the session in this room, but I just wanted to remind you that in the main auditorium, Professor Roberto Orecchia and Arnold Campos are giving a presentation in the framework of the Aristotle Medical Forum in the session of the role of artificial intelligence in radiation therapy. So I encourage you to just step in the main auditorium. Thank you very much.